Good afternoon, everyone. Thank you, organizing committee, for giving me the opportunity to speak. So I have been presented with this abstract, NRG GU011. It is a phase 2 double-blinded placebo-controlled trial of prostate oligometastatic radiotherapy with or without androgen deprivation. It was presented in ASCO GU 2023 this year. So a little bit on the background, there is no clear standard of care for biochemically recurrent prostate CA with PET detected oligometastasis but normal on conventional imaging. Phase 2 trials show that SABR, stereotactic ablative body radiotherapy to the oligomets may delay cancer progression and initiation of ADT. So ADT plus RT prolongs survival in locally advanced prostate CA and in conventional imaging metastatic prostate CA. However, there is a knowledge gap about the time and the benefit versus toxicity of ADT with SBRT in early OMPCs. So I searched on the NCCN guidelines, and I found there is no clear-cut guidelines in the NCCN for the oligometastatic prostate CA detected on the PET but normal on conventional imaging. Though there's a point that ADT for metastatic castration-sensitive diseases, they say that ADT with treatment intensification is preferred for most patients with metastatic prostate CA. So this study aims to evaluate the impact of relugolix when combined with SABR in oligometastasis. So mechanism of action of relugolix is that it allows for rapid testosterone recovery, and it has lesser cardiovascular events, that is 54% less compared to leuprolide, and therefore it is hypothesized to have low late ADT toxicities. So a little bit on the theoretical benefits of radiation therapy in localized and OMPC. Radiation delivered induces apoptosis and necrosis in the prostate cancer cells. SABR induces apoptosis and further disrupts the microenvironment. And fractionated RT induces necrosis, which may further induce immunogenesis and vasculolysis in the body. So a little bit on the compound relugolix. It is orally available non-peptide GnRH antagonist. It was first approved in Japan in 2019 for the use of uterine fibroids under the brand name of Relumina. And then it was US FDA approved in 2020 under the brand name of Orgovix for the treatment of advanced prostate cancer. Then it was approved by the European Commission in 2022 April. It's studied for the symptomatic treatment of endometriosis as well. So it's the first and currently only orally administered GnRH antagonist approved for treatment of prostate cancer. Similar to therapies like with degarelix, but degarelix requires a subcutaneous administration. Hence, it is less burdensome therapeutic option for patients who otherwise may need repeated clinical visits. So therefore, it has a relative ease of use, and it shows to have a superior depression of the testosterone level compared to leuprolide. So coming to the methodology of this trial, it is a randomized phase 2 double-blinded placebo-controlled trial with 2 arms, SABR plus 6 months placebo versus SABR plus 6 months of relugolix. The eligible patients are those with biochemical recurrence after prior curative intent radiation or surgery for localized prostate CA, PSA level of 10 or more nanogram, negative metastasis on conventional imaging, and 1 to 5 PET positive metastasis seen. The SABR is delivered in 1 to 5 fractions to a BED of 100 gray, followed by placebo or relugolix given as 120 milligram daily for 6 months. Patients will then be followed with imaging at the time of biochemical recurrence. The sample size planned is 260 patients at a predicted enrollment of 8 patients per month, and the estimated study completion date is 2026, late 2026. Also in this study, they will be stratifying further into extrapelvic nodes only versus bone plus minus nodes. They will also stratify as PSA doubling time less than 12 months versus more than or equal to 12 months, and fluciclovin PET versus PSMA PET. And the primary endpoint of this study is radiological progression-free survival on the conventional imaging Secondary endpoints are PET-based radiological PFS, the sexual and hormonal quality of life, other quality of life measures. They will also be studying an intergroup comparison of the time to salvage therapy, castration resistance, local progression in the SABR targeted lesions, biochemical progression, distant mets, prostate cancer specific mortality, metastasis-free survival, as well as overall survival. This trial will also be seeing the adverse event rates for both the treatment arm, and it will evaluate the genomic and blood markers of treatment response. So many endpoints. So I have taken a few studies on similar lines. So this was a narrative review of OMPC, which is an evolving paradigm. The conclusion of this review was that MDT, that is metastasis-directed therapy, has predominantly been delivered using SBRT in prostate cancer, and studies show that SBRT is well tolerated, gives excellent local control, and it can be used to delay ADT in a metachronous setting. This is another study which is an abstract which has studied adding ADT to PSMA PET guided SBRT for OMPC, which improves the distant progression-free survival. They did a median follow-up of all patients for around 9.6 months, and they evaluated 42 lesions which were evaluated at 6 months after SBRT with PET, out of which 40 showed complete response, 8 showed partial response, and 4 lesions showed stable disease. So to conclude, these prospective data, although non-randomized, suggest that OMPC patients treated with SBRT could potentially benefit from short-term ADT. Of course, a longer follow-up will determine if ADT simply just delays progression or truly alters the course of the disease. This is a systematic review on RT for OMPC, this study has included a large number of original articles on oligometastatic prostate CA, and it demonstrates that there is a therapeutic potential and challenges of metastasis-directed therapy for OMPC. The conclusion of the study was that there is relatively high sensitivity of PSMA PET increasingly found because it is used more and more for staging and defining this entity. Although there is no randomized data showing better clinical outcome by PSMA PET for oligometastatic disease, it can be assumed that a higher detection rate will allow more patients to be diagnosed earlier in a metastatic course. Although the role of ADT in OMPC treated with metastasis-directed therapy is still quite unsolved, but it is highly implausible that RT alone will ever be adequate. So concurrent ADT seems to improve the effectivity of metastasis-directed therapy. And lastly, I've taken a critical review published in the Red Journal for Radiation in Oligometastatic Prostate Cancer. This was published in July 2022. Trials assessing SABR have established safety and feasibility in OMPC. They all show a delay in the disease progression with treatment escalation by a median of at least 11 months and potentially more than 3 years. So therefore, they suggest a role for RT in the metastatic setting which goes beyond just the previous standard of care in which RT has been used exclusively for symptom palliation. And this is a summary of all the trials which have studied metastasis-directed therapy in hormone-sensitive prostate cancer, out of which the Oriole and the STOMP trial are the landmark trials in this category. The conclusion of this paper was that role of RT in systemic prostate cancer has historically been limited and palliative in nature, but the recent studies show a value of radiation, especially metastasis-directed SABR, in patients with limited metastasis. And this effect is noted in both hormone-sensitive as well as hormone-refractory prostate cancer, along with a significant improvement in biochemical and radiological progression-free survival. So thank you for your kind attention, and thank you to our patients who are our greatest teachers. Thank you.